Srinivasalu, Professor and Head of Department of Anesthesia, Vims Ballari, ex-President of ISAC Karnataka State Chapter, presented various papers and conferences and has many publications. And special interest is geriatric and regional anesthesia. And he's been an alumni, myself also, as a roommate of him. Welcome, Dr. Srinivasalu. Over to you.
Good afternoon, all. At the outset, I thank the organizers of SZISACON Karnataka 2023 for giving me this opportunity. I bring greetings from Department of Anesthesiology, Vims Ballari. And it's like always, whenever I come to MMCRI, it's like homecoming for me. This is the place where I have started learning about anesthesia, and my great teachers have laid a great foundation for whatever I am today. And this is the picture of 11th Karnataka State Conference, which was held during 1994 when we were postgraduates here. And all these are my great teachers and my PG colleagues. And Dr. Shripad is here. You can see then and now Shripad. Almost not much changed. Yeah. Yeah, thank you. So I'm going to talk about endocrinal emergencies during anesthesia. So I'm restricting myself to the most commonly occurring endocrinal emergencies, which include emergencies related to diabetes, mellitus, pheochromocytoma, Addison's disease, endocrinal emergencies related to the thyroid gland, acute hypopituitarism, and hypoparathyroidism. So these contribute to nearly 2% of all the hospital admissions, and we encounter these emergencies either as a first responder in the emergency room or during optimization of these patients before surgical intervention or during intra or post-operative period. And we should have high index of suspicion in diagnosing and managing these patients, because our individual exposure to these endocrinal emergencies is limited. So diabetes mellitus is the most common contributor for the endocrinal emergencies, which include hyperglycemic, hyperosmolar state, diabetic ketoacidosis, hypoglycemia, and the incidence of diabetic ketoacidosis is around 1%, which is more common than that of hyperglycemic, hyperosmolar state, but the mortality rate is higher in hyperglycemic, hyperosmolar state compared to that of diabetic ketoacidosis, which is around 10 to 20%. So diabetic ketoacidosis is defined as the biochemical triad of ketonemia, hyperglycemia, and acidemia, seen more commonly in type 1 diabetes mellitus patient, especially middle-aged patients, and it is because of relative or absolute lack of insulin with concomitant increase in the counter-regulatory hormones such as glucagon, catecholamines, cortisol, and growth hormone. In nearly 25% of the patients, there may not be any obvious precipitating cause, and commonly it is because of suboptimal management of insulin treatment, and because of stress related to the infections, myocardial infarction, trauma, surgery, hypothyroidism, or it may be drug induced in patients on steroid supplementation or sympathomimetic drugs. So lack of insulin or increase in the counter-regulatory hormones because of increased stress results in hyperglycemia and release of fatty acids, which will be oxidized in the liver, resulting in the release of ketone bodies, which will accumulate and release hydrogen ions and result in sorry for this, it is MP. Okay, it results in metabolic acidosis, and hyperglycemia lead to osmotic diuresis, which also causes the loss of electrolytes such as sodium, potassium and phosphate, in addition to water and glucose. So diagnostic criteria includes moderate levels of hyperglycemia, that is around 300 milligram of deciliter of glucose, and moderate serum osmolarity, which is less than 320 milliosmoles, but significant reduction in the pH and bicarbonate levels, which indicates metabolic acidosis, and moderate to high serum and urine ketone bodies. Clinical features and consequences include hyperglycemia resulting in osmotic diuresis, hyponatremia, hypokalemia, volume contraction resulting in signs of dehydration, and acidosis resulting in hyperventilation with typical Kussmaul's breathing, nausea, vomiting, and weakness, lethargy, and coma. And management includes, initially it is most important is correction of fluid status and tissue perfusion with 1 to 2 liters of normal saline or equivalent, which should be given over 1 to 2 hours, followed by 20 ml per kg per hour of infusion of normal saline, and we may have to use vasopressors and inotropes to maintain blood pressure and tissue perfusion. And hyperglycemia is managed by effective dose of insulin with a loading dose of 0.1 unit per kg of regular insulin, followed by infusion of around 0.1 unit per kg per hour. And rate is reduced when the hyperglycemia and bicarbonate levels are moderated, and when the glucose level falls below 250, we have to add a glucose containing fluid for the intravenous fluid therapy. And whenever the blood metabolic acidosis is severe, that is blood pH of less than 7, we may have to use sodium bicarbonate by calculating the deficit, and half of it has to be infused during the first 3 to 4 hours, followed by the remaining half in the next 24 hours. And potassium and phosphates are replaced once we ensure the adequacy of the urine output, and most important of all is the identification and prompt treatment of the comorbid or precipitating cause for this diabetic ketoacidosis. Next, next, why it is jumping? It's just moving without anything. It's just moving. If I leave it, just it moves. Yeah. Next important complication is hyperglycemic hyperosmolar syndrome. It is seen in type 2 diabetes patient and elderly patient, and it is caused by plasma insulin concentration that are inadequate to maintain proper glucose utilization, but are adequate to prevent ketolysis, lipolysis and ketogenesis. And again here the hyperglycemia, hyperosmolarity and volume deficits are more severe compared to that of diabetic ketoacidosis. Diagnostic features include high severe hyperglycemia and high serum osmolarity of more than 350, and moderate metabolic acidosis with pH of around 7.3 and bicarbonate of around more than 15 milliequivalents per liter. It is typically the clinical features and symptoms are of slow onset over days to weeks, There will be clinical features related to hyperglycemia like osmotic diuresis and consequent dehydration, signs of hyperviscosity and thrombosis like delirium, coma, seizures, and motor deficits, and patient might have moderate degree of metabolic acidosis also, but there is no ketoacidosis. Management includes again correction of hypovolemia, with if the plasma osmolarity is more than 320 milliosmoles per liter, we may have to use hypotonic saline 1 to 1.5 liters over 1 to 2 hours. And once the plasma osmolarity improves, that is, it comes down to 320, replace it with isotonic saline with 1 to 1.5 liters per hour of the fluid. It is followed by insulin therapy with IV bolus of 15 units of regular insulin, followed by again 0.1 unit per kg per hour of insulin infusion. Then once the plasma glucose levels comes down to 250 to 300, we can reduce it to 2 to 3 units per hour, and electrolyte deficits are less severe compared to that of diabetic ketoacidosis, and potassium is replaced if required once the urine there is adequacy of urine output. And always volume replacement has to precede insulin therapy to avoid circulatory collapse. Next another important complication is because of hypoglycemia, which is diagnosed by Whipple's triad, which shows the symptoms of hypoglycemia, serum glucose of less than 45, and the symptoms disappearing after glucose administration. Hypoglycemia may be fasting, such as which occurs in critical illnesses such as hepatic failure, cardiac failure, and hormonal deficiency because of cortisol, glucagon, hyperinsulinism. Postprandial hypoglycemia can occur in post-gastrectomy or galactosemia. Again, clinical features depends on the level of plasma glucose. If the plasma glucose level goes below 70, there can be subclinical stress response, and if it is less than 55 milligram per deciliter, there will be activation of autonomic nervous system with symptoms of sweating, palpitations, tremors, and hunger. This will be masked if the patient is having autonomic neuropathy. And if the blood glucose level goes below 45 milligram per deciliter, there can be neuroglycopenic symptoms such as behavioral or cognitive impairment, drowsiness, blurred vision, seizures, coma, and sometimes death. Treatment is to, the main goal is to achieve a blood glucose level of more than 100. This can be accomplished by use of 50 ml of 50% dextrose in water. And in resistant cases, we may have to use glucagon, hydrocortisone, and if the hypoglycemia is because of sulfonylureas, octreotide, which is a somatostatin analog, may be helpful. Next important endocrinal disease or emergency we encounter is pheochromocytoma, which is diagnosed by a triad of headache, palpitation, and sweating. And hypertension is present in most of the cases, which is paroxysmal in nature. And orthostatic hypotension is common in these patients because of contracted blood volume. And under anesthesia, if there is severe tachycardia and hypertension without any intraoperative cause, or in a patient who is not a known hypertensive, should raise a suspicion of a case of pheochromocytoma in undiagnosed case coming for a incidental surgery. And in known case of pheochromocytoma, crisis, that is the severe hypertension and tachycardia, can be precipitated by straining, exercise, pressure on the abdomen, and with anesthetic drugs known to produce sympathomimetic effects. And when systolic blood pressure is high, that is more than 200, or diastolic blood pressure of more than 120, we have to consider emergent treatment of hypertension, as if this is not managed properly, it can lead to cerebrovascular accident and sometimes even myocardial infarction. And whenever we are managing a case of pheochromocytoma, intraoperatively there can be severe cardiovascular instability, particularly during induction of anesthesia and tracheal intubation, during pneumoperitoneum, during tumor handling, and following ligation of venous drainage. Management of pheochromocytoma crisis is with the intravenous beta blockers such as phentolamine, phenoxybenjamin, and sometimes sodium nitroprusside to manage the hypertension. A beta blocker such as esmolol or labetalol are used to control the heart rate, and always it should be given once there is alpha blockade, because unopposed, if we use beta blocker as the first initial management, it can result in unopposed alpha mediated vasoconstriction, complicating the management of hypertension. Next complication is the adrenal insufficiency. It may be primary, like in autoimmune destruction of the gland; secondary, when anterior pituitary fails to produce sufficient ACTH, and causes are tumor, infection, and surgical ablation of the pituitary gland. And it may be because of inadequate replacement of steroid when the patient is on chronic steroid therapy. Symptoms include in primary idiopathic adrenal disease, it will be diffuse hyperpigmentation, chronic fatigue, weight loss, nausea, vomiting, diarrhea, and hypertension. And in acute crisis, abdominal pain, severe vomiting, diarrhea, hemodynamic instability, hypertension, shock, and altered sensorium. Treatment includes patients who take long-term steroids may exhibit signs and symptoms during period of stress such as surgery or acute illness. So perioperative glucocorticoid coverage should be provided for them. And in case of crisis, a bolus of 100 mg of hydrocortisone followed by continuous infusion at 10 mg per hour has to be started. And volume replacement has to be done with glucose containing fluids, and we may have to use vasopressors to maintain the blood pressure, and etomidate as it suppresses the cortical response should be avoided in these patients. This is a perioperative steroid supplementation needed for when the patient is on chronic steroid therapy. For minor surgery, it's around 25 mg of hydrocortisone. For moderate surgery, 50 to 75 mg, and for major surgery, 100 to 150 mg. And in intensive care or in crisis, it is 50 to 100 mg 6 to 8 hourly for 2 days, and slowly tapered over 1 week. Coming to the thyroid emergencies, thyroid storm is one of the rare complication. Even during my experience of last 25 years, I have seen hardly one case, that is suspected case. So it is a acute exacerbation of hyperthyroidism precipitated by trauma, infection, and medical illness or surgery. Typically there will be elevated serum levels of free thyroid hormones, hypermetabolism, and adrenergic overstimulation. Rarely occurs in Graves' disease or toxic multinodular goiter. It is more common in post-operative period, particularly in untreated or inadequately prepared hyperthyroid patients coming for emergency surgery. But if it occurs, mortality rate is high, nearing to 20%. These are the features of hyperthyroidism, that is anxiety, fever, hyperthermia, nausea, vomiting, diarrhea, delirium, psychosis. And if the patient is under anesthesia, there will be tachycardia, arrhythmias, signs of congestive heart failure, hyperthermia, increasing end-tidal carbon dioxide with a faster exhaustion of soda lime, and hypertension, and sometimes leading on to multi-organ failure. And the differential diagnosis is malignant hyperthermia and malignant neuroleptic syndrome. Treatment is initially mainly supportive with adequate hydration and active cooling measures like infusing cold saline, beta blockers to keep the heart rate below 90 beats per minute, dexamethasone 2 mg 6th hourly, or cortisol 100 to 200 mg 8th hourly, antithyroid drugs such as propylthiouracil crushed and given through the NG tube, and sodium iodide. All these drugs either reduce the conversion of T4 to T3 or 4 minutes more. Or they reduce the release of thyroid hormones. If atrial fibrillation with faster ventricular rate is present, beta blockers and digitalis may be used. Usually thyroid hormone levels after proper management will come to normal within 24 to 48 hours. And measures to reduce thyroid storm when the patient is undergoing surgery, thyroid surgery, is adequate preoperative optimization, adequate depth to be maintained to avoid exaggerated sympathetic response, and avoiding the drugs which stimulate catecholamine release, such as ketamine, or local adrenaline containing local anesthetics. Next is the other extreme is the myxedema coma, which occurs again rarely. It presents as delirium or unconsciousness, hypoventilation, hypothermia, bradycardia, and dilutional hyponatremia. Most commonly occurs in elderly women, and the common reason is non-compliance to the thyroid treatment, infection, stroke, trauma, or hypothermia. Again, mortality rate is higher here. Diagnosis is mainly by clinical features and reduced free T3, T4 levels. In primary hyperthyroidism, there will be high TSH, and in secondary hypothyroidism, there will be low TSH. And treatment consists of fluid resuscitation and maintenance of normothermia, thyroxine, mechanical ventilation depending on the level of support required, and we may have to use vasopressors and hydrocortisone. And the management is complicated by the difficult airway because of edematous airway, and large goiter, and risk of regurgitation and aspiration because of reduced gastric emptying or delayed gastric emptying, and reduced response to hypoxia and hypercapnia, complicating the resulting in difficulty in weaning these patients. In hypoparathyroidism, the main feature is the hypocalcemia, which can occur when there is accidental gland removal during thyroidectomy, or usually there will be transient hypoparathyroidism after subtotal thyroidectomy, and it can also present in autoimmune disorders. Clinical features are mainly because of hypocalcemia, resulting in neuronal irritability, tetany, seizures, stridor and apnea, hypertension, and diffuse encephalopathy and papilledema. These are the two signs which you have to remember. One is the Chostek's sign, whenever you stimulate the facial nerve in front of the ear, there will be twitching, and Troj's sign, which produces carpopedal spasm when the cuff is inflated above the systolic pressure. And the treatment is with calcium supplementation, IV calcium supplementation, and as alkalosis reduces the serum calcium level, always avoid respiratory alkalosis whenever you are managing a case of hypoparathyroidism. A last thing I am going to discuss about is the pituitary apoplexy, which is a rare endocrine deficiency syndrome due to partial or complete loss of anterior lobe of pituitary, which can occur because of surgical removal, or metastatic tumor, or during Sheehan's syndrome after the delivery. Clinical features include headaches, visual field defects, nausea and vomiting, and neurological deficits with altered conscious level. And the treatment is removal of tumor and hormonal replacement. And to conclude, endocrine emergencies are potentially life-threatening, and delayed in diagnosis and treatment increases the mortality, and proper understanding of pathophysiological process and prompt recognition and treatment will reduce morbidity and mortality. Thank you for patience hearing. Thank you.